Hi, I'm Katie Quatman-Yates, and I am excited to be giving this presentation for the LeaRRn Grand Rounds on selecting rehabilitation metrics that matter to guide transformative improvements for patients, clinicians, health systems, and society. My main objective for this talk here is to really, more than anything else, help encourage the audience to engage in deep reflection about where we are now and where we might go with things like metric selection. And I'm going to take a section of my talk here to talk a little bit about a topic I'll say where medicine went wrong, talking about implementation, and I'll convert that to a topic that I'll call lost in translation. And then a topic about use, where I would like to talk about some transformative pivots we might consider as we move forward into the future. And so really all of this is to kind of help think about moving our world in rehab to better supporting learning health system research and quality improvement initiatives related to our world. We have no conflicts of interests or disclosures to provide, but I am a faculty member at The Ohio State University. And my opinions that I share here, and there will be a few, are my own, but as much as possible, I do try to base them in evidence. So a little background about myself. I'm a little bit unusual in that I came to the world of rehab, having had my PhD in hand already. I was driven to the idea of doing research in organizational behavior, and really specifically thinking about how we can bring evidence into practice. How do we make it useful for people to make their practice improvements actually stick? And I approached it from the lens of using systems science and complexity science types of methodologies to really move that world forward. And in case you're not as familiar with systems science, I like to think of this about, taking strategies in terms of looking both at the narrow, kind of working in the weeds or in the forest itself, but also taking steps back to look at the system as a whole and kind of weaving our way in between both. So we have a good appreciation of what it takes at a high level and also down at the local level to make things happen the way that we hope that they'll happen. For my dissertation, I became very interested in thinking about how it is that science or new knowledge becomes available and gets spread among a group of learners or a group of scholars. And if you haven't ever read this book by T.S. Kuhn, The Structure of Scientific Revolutions, if you are a researcher, I suspect that this will make you think entirely differently about the way that you've learned and what you know and how you approach science. It kind of flips the way that we do science on its head and makes us think critically about where it is that our knowledge actually comes from and how it's shaping the world as we know moving forward. And so I got really interested in this, and that was exactly what I decided to do my dissertation on. And really quickly, I'm just going to give a brief synopsis of this, which was a long time ago, but still relevant today. So when we're taught about science in, say, elementary school, our early exposures, we're often sort of framed to think about this from the perspective of this maybe really intelligent person working alone, pursuing knowledge, pursuing advancing knowledge, experimenting, really just engaging on the forefront and the frontier of the way that we know about. And the reality is, and this is what T.S. Kuhn pointed out in The Structure of Scientific Revolutions, is that in fact, there are many scientists out there and they're working all very hard to advance knowledge. But when we really think about it, what's actually going on is many of these scientists are actually working together and informing what each other does. And so when we think about scientific knowledge on a systems level and how information gets spread and put into practice across a wide scale of people, we have to actually think about those relationships. And so one of the things I was really interested in doing is trying to understand how a field emerges and how we sort of lay the social pipeline of interactions between one another to share ideas and to actually get them out into the literature and then cite it in the future. So my dissertation was on the social construction of knowledge in the field of sport management. And I used social network analysis, which is a form of kind of complexity analysis, to map co-authorship across an entire field of study. And what you actually see here in the figure are the red dots represent nodes or individual authors that emerged into the field. The blue represents if they had ever authored together. The thickness of the blue lines represents how many times they authored together. And then the shape that you see here is actually the overall structure of the network in terms of who had co-authored together among the entire field of authors that were included in the study. We were also able to map over time how this entire structure emerged. So this was the entire body of co-authors from 1980 to 2006. But prior to 1985, what you can see is it started out as a few scattered researchers. And over time, they each had students that kind of grew. So they had their own little stars and sort of clusters of work together. And over time, again, started to see some of these clusters come together. More people enter the field and more clusters emerge. Starting to see those clusters cross over and really work together to form that entire network as a whole. And what also is interesting about this is that you can play a little bit of the social network game with a network of co-authors. And if you've heard of the Kevin Bacon sort of 6 degrees of separation theme, where everybody is sort of connected to each other with a few star actors who can be connected to many, many others in that network. The same was true in this co-authorship network, in that there were 4 out of the 5 most connected scholars in the field were all faculty from the same institution. And so I say all this to acknowledge that the way that science emerges and the way that we embrace it as users of science is very socially constructed, and often socially constructed by a few star people or players in the field. So from there, I actually made a transition and got my DPT degree. That's a picture of my twin sister and myself when we were both working at Cincinnati Children's together. And if you look closely, you can see that I actually have a number of different stats books on the table. We're both working on analyzing some data in some different ways. Which brings me to the topic of today's talk about sort of thinking about metrics in rehabilitation science. And my personal philosophy about metrics is that, it's really important to realize that we have many tools in the toolbox. When we're selecting metrics, it's often easy to go back to the way we know how to analyze things, or the way that we've done it before, or thinking really specifically in a narrow fashion about the data that we have available and what we're capable of doing with that data as we've been trained. So knowing that that's my philosophy, let me just share a few examples of the different types of data that I've worked with. I've worked with physiologic data, heart rate variability, respiration rates. I've worked with postural sway data, both in terms of the classic ways we look at it and also with forms of complexity analysis. I've looked at biomechanical data. We've done trajectory analyses. I've used qualitative data. I've even helped map networks in the brain. This is patient-reported outcome study. This is a study actually using accelerometers on surgical doors to help with a quality improvement initiative. And some of the things I've been most interested in lately is trying to do full system change through quality improvement initiatives, where we actually kind of leverage things going on at the individual level and appreciating quantitatively and qualitatively at those smaller levels, how they build together at the systems level for full group or full system change. So I had mentioned before that what I was really interested in doing was thinking a little bit about metric selection and encouraging you to think about how the ways that you're working toward picking your metrics that you're using for either research or clinical purposes, and how they have been shaped by either your history or history of science in general, or history of clinical processes in general. Also thinking about philosophy. Much of our metrics in the healthcare world have really been driven by sort of a positivistic slant on the world, and thinking about why it is that we are mostly tied to especially quantitative measures. Also how structural, and I'm loosely using the term isms here because there's many isms that we can think about that have shaped the way that we are collecting data and using it. Racism, sexism, colonialism, capitalism are just a few to name. And also increasingly, we're seeing the world of politics really shaping the metric selection that we're engaging in. On the left here, I've actually put a book up there that when I was making the transition into the rehabilitation sciences, one of my mentors, Mike Riley, had encouraged me to read. And the book was called Where Medicine Went Wrong by Bruce J. West. And it really does kind of make you think hard about the math and the sociology of science in terms of what data can do and how different ways we analyze it actually provide more or less resolution of data for interpretation, and how informative actually can be for what you're trying to accomplish. So specifically in Where Medicine Went Wrong, there were a number of points that were made, but some of the key ones were the point about lack of complexity in the way that we've approached medicine. And really specifically thinking about reductionism over holism, linearity over nonlinearity, math over context, and static over dynamic. And I'll dive a little bit into each one of these. The point about where medicine went wrong is that early on, and most likely, because of technology, availability of data, just the general shape and evolution of science as a whole, we were leaning towards things that were kind of simpler to process and trying to think of the world in a simpler state. And that was maybe necessary. But now we have advanced technology. We have more nuanced understanding of the way that we can use data, and a more, I guess, complex network of people with different skill sets that we can bring together to really do amazing things with data. And so maybe we can be thinking about reversing some of those old approaches and making new discoveries through more advanced ways. Digging a little bit into the reductionism over holism principle, on the one hand, reductionism sort of assumes that things can be reduced to individual parts versus holism, which sort of assumes that we cannot be reducing things to their individual parts and fully understand the way that the system is operating. So I use this picture here to sort of acknowledge that, like, yes, you could understand maybe the blue rope and what it was doing on its own, or the red rope and what it was doing on its own. But when they are intertwined, the only way to understand what they're producing, which in this case is a knot, is to appreciate that they're coming together to form more than they would individually. And so if you're going to approach it from a reductionist standpoint, you should appreciate that you are doing it from a reductionist standpoint, versus if you're working from a holistic standpoint, you'll have maybe a wider picture, but maybe what you're looking at may or may not give you the whole picture that you're trying to capture. We can look at data in so many different ways. The same set of data can be used in just many, many different ways. And so I wanted to give an example here just to show you visually about how we're already doing this. We may see things like bar graphs and radar graphs, and up top there's a statistical process control chart. And we're used to seeing data in certain ways. Bar graphs are very common, and especially when we're talking about different types of variables, often we'll see maybe a bar graph presenting different variables in a dashboard form or something like that. Versus a radar chart, which may give us at the individual level some comparisons across many variables. And the statistical process control chart can be used for a lot of different advantages, especially at looking at things over time. And so tying that back to reductionism versus holism, depending upon what you're actually trying to capture, are you trying to capture a metric in its reduced form, in its reduced context, or are you trying to look at it in more holistic form, in its more holistic context? And the metrics and the way that you represent that data can be really important. For the linearity over nonlinearity component, some of the big things that people stress are really thinking about emergence, dramatic shifts, and attractor states. So a lot of our classic ways of training people to do science and to analyze and measure things is really in that more linear mindset. So I have that line, kind of a representative of a line graph. That's kind of that linear analysis kind of thinking approach that we're working on. The complexity side of things suggests that actually there are some cases where we have emergence that can occur, so more than the sum of its parts. And sometimes you'll see this tied to sort of the butterfly effect type of modeling, where a butterfly flaps its wings and something big happens on the other side of the world that would not be predictable given more linear types of modeling techniques. We also, in complexity science or nonlinearity sides of that, would be talking about dramatic shifts or tipping points. A good example of this is we can talk about, in some more linear ways, heart rate, but what we may actually be experiencing if we're trying to capture the whole kind of folding point of what's going on with the heartbeats, it's actually kind of a dramatic shift that we see. It's kind of a buildup of electrical current that it leads to this event that occurs. And so while there are some consistencies that are going on there are some different ways of analyzing what happens with those events that are repetitive, but also have some degree of randomness to what's going on. And there are ways using complexity analysis and complexity science techniques to appreciate what those dramatic shifts are and how important they are to shaping the way that we can understand and react to our world. And then finally, there's another area that the linearity over nonlinearity sort of matters, and that's in the idea of attractor states. A good way to sort of tie this to the way that we think about things in medicine is, I like the phrase, the rich get richer, but to a certain extent, it's about we kind of gravitate toward these attractor states. And if we don't capture and set our data up in the right way to capture what may be going on, we may have dramatic inequities going on. Health equity research is, replete with a lot of examples of how this may be happening. And so our need to really think about the fact that attractor states can occur should factor that into our metric selection and, maybe be able to capture things we may not otherwise be able to capture. So the math over context point. I think many people are familiar with the quantitative over qualitative types of premises. So a lot of us are trained, at least early on, in the world of kind of doing quantitative things. And I know these are sort of junk terms, so I'm using this to kind of more set the stage. That over time, we are in healthcare seeing more qualitative types of research being done, but historically speaking, the quantitative, at least in the more modern centuries, have been in that quantitative realm. We've also been emphasizing probability and prediction over description and understanding. And again, that aligns with a lot of the way that science and analysis have evolved over our historical periods here. And when we are working in probability and prediction over description and understanding, a lot of times what we actually end up doing with outliers is that we ignore them or we drop them, versus kind of trying to visualize outliers as a great opportunity or critical sources of information. There's a good amount of research coming out related to positive deviance and even sort of negative deviance. So the people that are in the extremes can be very informative. If you have an example of, a really bad problem, say many people dying of a certain disease in a third world country, and there happens to be a couple of success stories of people who have been able to successfully avoid that disease, you can ask questions like, well, what are they doing that nobody else is doing? And how do we bring everybody else into the space of what they're doing to make sure that we actually bring our numbers up, rather than working with sort of the law of averages and things like that. At the other extreme, we can use sort of negative deviance, and we do this a lot with major medical events where you go into a root cause analysis and try to learn from that scenario to inform making sure the things that you're doing, that what happened doesn't happen again. We can use these more to our advantage than we do to maybe not as such extreme cases, but looking at extremes, the positive deviance, the people in the outer limits of our distributions, to inform what's happening, and also viewing them as, we see this a lot in different types of analysis where we may use quartiles and things like that, but appreciating that what happens in those are actually subpopulations or subgroups that can be very informative in and of themselves. And so there's a lot of opportunity for us to look at more of that kind of subgroup analyses, especially as we get more and more in the big data world. An example I'll tie to this math over context, I think increasingly we're seeing, and I'll say this is with a little bit of tongue in cheek, but the PRO woes, or patient-reported outcome woes, and how we're trying to emphasize bringing these into our clinical practice. And Chad Cook recently has put out a couple of articles that specifically talk about minimally clinically important differences, or MCIDs. The title of one of his recent articles was on may not be so meaningful, important, or clinically relevant after all. And he raises some really good points. And I think, many of us from a clinical standpoint can come to many examples where, this PRO that maybe we are working on or using isn't really so useful at all. I know when I was working at Cincinnati Children's, sometimes we were using, for lack of not having anything, some adult designed tools. One of them was the Quick Dash. And I remember the first time I gave the Quick Dash to a patient who was 6 years old, and his parent was helping him fill it out. His parent happened to be a biostatistician. And the son looked at his dad and said, I don't use a knife. How do I answer this question? And it was, a really interesting and fun discussion point with the father, who was a statistician, to try to explain how relevant this data really is in so many different contexts. But you can think of it as is this really what we're going after? Is this patient, that the information this patient's providing me, really relevant to them? And it's easy to think about it in the age context, but there are many other contexts in which a patient-reported outcome that we're giving them just really isn't going to be all that highly relevant. We're also using them in some slightly different ways about, does actually having a minimally clinically important difference mean all that much? Because most of the time they're designed for statistical relevance and not necessarily on what is meaningful for that patient. So even though they're called patient-reported outcomes, the outcomes that we're using are not so patient-centered a lot of the time. And that last point of static over dynamic, a lot of the work that we've been doing in the past has been very historically based in a lot of laboratories where we actually try to control and have a perfectly, well-controlled study environment with people who fit very strict inclusion exclusion criteria, and it's almost often a snapshot in time. But in contrast, in the real world, we're often working with an environment that is much more tumultuous to that. It is not as controlled. And so putting something into that environment that worked in a laboratory, it's just kind of unpredictable about what you'll get out. And it's also unpredictable as to what it is that's influencing directly the outcome that you're seeing. So from that where medicine went wrong standpoint, there's a couple of points to emphasize there. And that is really thinking about more how past influences are, influencing the present state and future states, and not just trying to forget that the past may have occurred. Also, time offers an important dimension of information. And if we're going for simplicity's sake, because a lot of times it's very expensive to conduct a research study, and we're getting very high-level equipment, intensive data collection periods of time, that it's often hard to get that longitudinal data that we want, especially in the big numbers that we want, and especially in the real world situation. So thinking about how it is that we're going to be going after metrics that actually reflect the more tumultuous environment that people will be living in, but still allow us to enhance our understanding, is an important direction for us to move forward to in the future. Okay, shifting gears a little bit, I want to talk a little bit more about metric implementation. And I'm going to phrase this as lost in translation with a series of questions that I would encourage you to ask yourself whenever you're thinking about metric selection. I think many people are familiar with the DI-KW model, which talks about how, of course, there's data and there's lots of data out there. A subset of information then can come out of that data, and if you work on that in a strategic way, that information can then move into the knowledge realm where we can actually know and glean some information from that. Moving into the wisdom space, that's kind of taking the widest lens about how the knowledge that we have and what we want to use it for and how we can use it to our advantage is the smallest amount of sort of measurement going on out there. And we are constantly trying to work toward the wisdom, but most of the time we're living in that data to information, and at best information to sort of knowledge space. And so I think it's really important to think about it when you're choosing metrics, whether it be for what you're going to give to an individual patient or at a clinical level, what kinds of information are you going to collect on a given patient population, or at the health system level, what are we going to collect across to establish value for our patients? All of these matter, and with technology, we are increasingly able to get a whole lot of data right at our fingertips. But how much of that data is really useful? And when you're designing your metrics, it's easy and tempting to go to, oh, we already have this available, so we're going to use this as a surrogate measure for something that we want to know about, without really thinking about how much that data really actually lends itself to working toward the wisdom realm. Another big question to ask yourself is measuring for what purpose? It's one thing to go out there and say, hey, we want to do quality improvement, or we want to do some clinical managerial innovation, or maybe we're doing research. We have a whole lot of examples where we picked metrics from research and tried to drop them into clinical environments. And, they weren't designed necessarily the same. On the one hand, we're designing them for psychometrically sound ways of detecting differences between groups. But in another case, from a clinical perspective, perhaps we don't care so much about the statistically significant capabilities for detecting some sort of change. There are certainly some clinical scenarios and clinical questions where that matters, but it's not by and large something that we have to live our rules of engagement by. We can use measurement for a lot of different purposes. And sometimes a simple, one simple question in a qualitative form can be even more informative than the best possible, well-designed, psychometrically sound patient-reported outcome that we've implemented system-wide, depending upon the purpose for what you're trying to use that metric for. This is a figure from a white paper from the Institute for Healthcare Improvement. And I really like this because I think it helps me guide myself into remembering which space am I working in when I'm talking about picking a measure for something. Another big question to ask yourself is, for who is this really for? If I'm collecting data and the metric matters and I'm doing it for the patient, what the patient cares about is probably, maybe many cases, very different than what the clinician cares about. And what the clinician cares about may be very different from what their bosses care about or what the health system administrators care about. And so, when you're designing data collection measurement tools, thinking about what are you really doing this particular measure for? And trying not to make too many leaps about just because you collected something at the patient level doesn't mean that should necessarily drive all business decisions. There's a lot going on in the context piece of things that makes it difficult to make that kind of leap from one context to a different type of use. And who are we trying to use this information for what reasons to inform? And this lends itself to thinking again about that what level piece. I think many people are familiar with the socioecological model, where we're talking about sort of the layers of different individual to interpersonal to sort of like community level or environmental. And you can talk about the layers and how these influences all impact each other. And when we talk about the healthcare world, it gets particularly complex. This is actually a diagram created by one of my PhD students, James Crick, where he was working to model some of the different things to care about at the acute care setting, and how at the patient level, there's some things going on. At the unit or ward level, there's some things going on. At the systems level, there are some things going on. And at the external level, there's some things going on. And all these can have influences on each other. And being aware about where our influences are can be really, really helpful in terms of understanding the data and metrics that we're working toward. And then to think about, do the measures work together and align well? So things that you're collecting at the patient level could, in theory, work well with the clinical level metrics, but it takes a lot of thought. It's not always easy to extract something that you've collected at the patient level to a clinical level metric and vice versa, or to the health system metric. But thought about well, you can actually build a system of metrics to yield results that are really, really powerful. There's this quote, the system is perfectly designed to achieve the results it gets. And I think it's really important that we keep that in mind, that most of the time, the metrics that we're getting, maybe it seems frustrating. Maybe we're not turning the dial on things. We're trying to improve things and they're just not, the dial isn't moving. And it's a good time for you to ask, if you're experiencing that, are your metrics too simple? Have you really thought about how what's being collected at the patient level truly is helpful for health system metrics? Readmission rates are a great example of something that is so complex, and what's going on at the patient level metrics may not always be directly informative of the health system metrics. It's really got to be this combination, and how are we going to sync together to make all these sort of proximal metrics we may be collecting informative to our distal level outcome, something like readmission rates. And finally, thinking about, do the measures that you're selecting actually help drive actions toward improvement? Are you collecting data for data's sake? Are you collecting data because someone told you to? Are you trying to work toward metrics that you can't actually change because somebody above you or around you set a goal that didn't make a whole lot of sense for the things you're actually working on? And do these actually align with an actual improvement plan? How many times are you sending out data that have no real strategic plan to improve? And so thinking about your metrics with a real intention toward improvement can be really, really helpful. All right, so shifting toward my final stage of the talk here, I'd like to talk about transformative pivots for us to really think about in the rehabilitation world as we move forward. And to do this, I would like to share the 4 pivots from Sean Ginwright. If you haven't read this book, I found it wholly enjoyable and really appreciate where he was coming from, and has really shaped my thinking about how we move forward with all things in terms of transforming and being innovative, especially in the justice, social equity space, really thinking innovatively about transformative change. Highly recommend this book, but as a citation, I just want to acknowledge that I'm using his 4 pivot framework to kind of shape the direction of the next few slides here. So the 4 pivots that Dr. Ginwright suggests are from lens to mirror, from transactional to transformative, from problem to possibility, and from hustle to flow. For the lens to mirror, Dr. Ginwright talks about, a lens is an outwardly focused examination about how the world works. But our lenses over time can also create obstruction spots because lenses are awful at reflecting back the truth. And I like this picture here sort of tied to that, to think about, we give people glasses and we maybe use magnifying glasses to help us get clarity about a certain situation. But in doing so, we often lose the bigger picture going on around us. And so I would encourage you to think about what data that you are collecting that may actually have a very narrow-minded focus on it. And is it possible that not only are you not capturing what you really want to capture, but perhaps you can actually do some damage by picking a metric and having people drive toward that metric that has a cascading effect to something you really don't want down in a different location in your ecosystem. An easy example of this is a lot of our pushes toward productivity standards versus desired outcomes and how we often feel the tension between that. I think most clinicians would say they wish they had more time with patients. They'd really like to dig into their whole wellness and healthcare piece. And instead, a lot of the times, the things that they're most judged on is how many patients did they see in a given day, or how many services did they deliver? And what kind of, contrast are we setting and pressure are we putting them under when we're actually trying to hold them to really high level productivity standards that may not directly align with the patients that they're treating on an individual basis right in front of them. And so really thinking hard about this tension between what we're setting our metrics up to look at and our actual desired outcome and how we're going to make sure we balance those out. Maybe that means adding a separate metric so you have some balancing measures going on. Maybe that means thinking harder about the expectations you set. Maybe that means setting different subgroups out from the forefront so that it's not just a blanket standard for everybody, but you allow for context to be brought into the picture. But in any case, it's really important to think about what are our metrics actually reflecting back at us, and for us to think about, is this actually reflecting the picture that we want or improving whatever it is we're trying to improve? Talks about transactional to transformative. So mainly this is in the context of relationships. So let me say these two quotes here, just so you kind of get a sense of where he was going with this. But transactional roles are based on the performance of roles and the execution of tasks. Most of the time, transactional relationships are defined by the titles, our jobs or occupations. Transactional relationships help us get things done quickly without having to figure out how to engage with all the roles we play. Transformative relationships, on the other hand, are based in those features of life like care, vulnerability, love, curiosity, connection. Transformative relationships are formed when we exchange pieces of our humanity with each other. They're messy, confusing, and time-consuming. They force us to see things about ourselves we normally hide from. And I think this is a key point here in that, it's not, if we really want to get to metrics that are extremely meaningful and help capture the human element, then we really have to think hard about what are we doing in terms of setting up our metrics that actually allow us to capture the messiness of humanity, to reach a full understanding and appreciation of context, and one in which it's meaningful to both the people that are trying to do the measuring and the people that are getting measured on any given phenomenon. So, this is a little bit of a rough example, back to the PRO woes. Are we really capturing what we want to hope for capturing? If we set goals like achieving a minimally clinically important difference, I guess we can assume that somebody's going to be getting a little bit better, but is it actually meaningful? And if we're trying to set a goal about, does our rehabilitation treatment actually help the patient get what they really want to achieve, there's a lot of questions there, right? And maybe the goal shouldn't be around MCID, but rather a cure. I think a goal for all of our patients would be that they come away even healthier than they came in. And how are we setting our metrics up to capture that? And our force toward quantitative metrics, I think, is a big concern to address. If somebody's really upset, are we going to try to quantify the number of tears they shed and then try to reduce the number of tears they shed in a single visit? There's a lot of sort of unrealistic things that we're asking of our data right now that aren't truly capturing meaningful things, and certainly not the human element that we may be going after. So thinking hard, especially about our patient-reported outcomes and what we can do to leverage them or to actually just make sure that they're a small tool in a much wider toolbox. From problem to possibility. So our job is to lean into practice of possibilities and strive for the future we want to create. It's really hard given the urgency, scarcity of resources, and limited time. But if we're in the business of deep change, we also have to transform what we believe is possible. And here I give the example of a book that recently came out called Upstream. If you're familiar with the old parable about trying to actually get at the root cause of people who are, maybe you see a child kind of coming down the river and you save them. 5 minutes later, you see another child coming down the river, save that child. And you keep saving more children, but you don't go back upriver, upstream to figure out what is the real cause of the same problems that you're seeing over and over again. We have a lot of opportunity to shift our metrics and our lens of change upstream. So thinking about where are your metrics? Are they working at the downstream level or the upstream level? And I'll give a quick example of that in terms of healthcare. One of the groups that we were working with was community paramedics. And what they were noticing is that some of their individuals were actually calling again and again for fall-related calls. And what they really wanted to do was to help get that person the help that they needed directly in their own home. So they would stop getting maybe hurt or calling for a lift assist. And so could they on an individual level reduce the number of calls? Thinking about that at a systems level, if they targeted all their individuals who were most vulnerable in the community, could they actually reduce the number of fall-related calls and transports per month? And I share with you the citation that shows our work in this area through quality improvement initiatives. But what this actually shows is that over time, by targeting a subgroup of very vulnerable people, we were able to have system level change in the metrics that desired, which was exactly what our goal was in the first place. And the final thing that Dr. Wright talked about was working from hustle to flow. He reflects on, to-do lists aren't bad in themselves. They're just symbols of how capitalist culture permeates nearly all aspects of our lives. The capitalist culture is the values and core beliefs about how our economy and society should be organized. Values like individualism, privatization, unregulated profits, productivity, and competition permeate our daily lives. And these values tend to determine the value of human beings based on what a person can produce or earn. And the reality is, if we're going to have metrics that are actually useful in the rehabilitation sciences, that reflect on the human values we're actually trying to promote, it's going to take time, it's going to take resources, and it's going to take brain power, which means we have to get out of our daily grind of, meeting really extreme productivity levels. We have to take a step back and take the time to get to know and really think about and work with other experts in terms of creating metricing systems that are particularly valuable and help us capture the human experience. As an example of this, I just wanted to share how we were working on an initiative to get more patients out of bed for meal times on a floor in one of our local hospitals. And we were having a lot of success just by kind of doing some different implementation strategies. And all of a sudden they had a massive nurse turnover on the floor, and all of our work just started to kind of fall apart and unravel. In large part, the nursing turnover was becoming a part of the high productivity standards and them not being able to do what we were asking them to do, which was to give their patients better care by helping them get out of bed more often. And so we had to shape and reshift our emphasis in terms of how we were going to approach this. We're still working on this problem, by the way, but I wanted to show in this particular set of data how a mix of quantitative and qualitative data allows us to track our metrics over time and also add in some of the qualitative context about what was influencing our numbers at any given point in time. So it's really a good way of mixing some data for real knowledge translation in a single visual. So with that, I'll recap by the biggest goal of this presentation was hopefully to help you engage in some deep reflection about where we are now and where we might go with metric selection, implementation, and use as we work towards supporting our learning health system research and quality improvement initiatives.